oncology unit, Dr. Satish Kumar Anandhan. He completed his MBBS from Government Chengalpattu Medical College from Tamil Nadu and obtained MS General Surgery from Safdarjung Hospital, one of the prestigious institution in India. And he earned the surgical oncology from AIMS, and he is a former visiting fellow at NCC Tokyo. And currently he is working as a consultant in surgical oncologist at Apollo Medics. And his surgical expertise he specialized in head and neck cancers, surgeries, and breast cancer, gynecology cancer, colorectal cancer, pancreatic cancer, and stomach cancer, and gallbladder surgeries. And he served as a president of Resident Doctors Association at AIMS Patna. And he contributed in various publications, including a paper on comparing Desada tissue repair and Lichtenstein mesh hernioplasty. And while he's come to the achievements, he secured gold medal in MCH surgical oncology from AIMS Patna, and gold medal in MS general surgery at Safdarjung Hospital, and secured overall second rank in MS generally at the university. And he attended the International Robotic Conference, and he authored several research papers. And he is the founder of the Adarva Foundation, conducting mobile medical camps for the peoples in rural communities. And he also mentoring lots of students, an exemplary role model for many students like us, and always willing to guide us in any way he can. And welcome you, sir. Over to you, sir. Thank you so much for joining, sir.
Thank you so much, Dr. Hari, and thank you so much, Dr. Sridevi. That's so kind of you, and thanks to the team Nama Medicine for this great work you guys are doing to the society as well as to the medical students level. So shall we proceed without wasting any more time?
Sure, sir.
Sure. Can I have my screen, please? Perfect, Hari. I'm able to see the screen. So let's have a very cool and calm session today, guys. So breast cancer, it's a very huge topic, and completing and compiling this topic in a very small session of 30 to 40 minutes is not a doable task. So I just want to be very practical and very easy with all the students here. So if I'm not wrong, the majority of crowd we have are medical students, right? Undergrads. Am I right?
Yes, sir.
Yes, perfect.
Yes, sir.
Perfect. So only thing I need from you guys is just let it be a kind of interactive session. So I will not poke so many questions at you. So, but I request you all to have n number of questions, whatever you want to ask me, so that it's something like I am attending a Viva session from you guys. So whatever kind of stupidest questions you have, you please ask me. So I have to navigate this topic in such a way that it is not too much complicated for an undergrad level. So I should not handle this topic in a super special level or MS level. So if you are not able to understand at any point of time, please speak out. So we are here to learn. So I'm here to learn with you guys. That's the whole intention of this topic. With this, we'll go ahead. It's a very short topic. We'll have only for 20 to 30 minutes, then we'll wind it up. So moving ahead, next slide, please. Next slide. Yeah, perfect. I think we are back, Ari. Perfect.
Yes.
Just stay there. Okay. So I don't want to take this topic in a conventional way, guys. Like whenever you see this topic, right, you can see n number of PPT in nets and n number of videos in YouTube. So it says that what are the common symptoms, what are the risk factors, what are the diagnosis, what is the treatment. So I don't want to take it in a very conventional way. So I just want to know what is the perspective of a surgical oncologist whenever we see these kind of cases, and what we want from an general physician or undergrads to know about this cancer and how to stage them, and what kind of treatment principles that should be followed. So that's the whole intention what we are going to learn today. So this is a commonest cancer in Indian women. There's no doubt wherever you are doing there in northern, southern, or western, eastern part of India, or anywhere in the country, you will definitely see a breast cancer patient and survivor for sure. So that much breast cancer is very common worldwide. It is in India, it is 25.8 per 1 lakh women is a quite high incidence. If you see 50% or earlier breast cancer, 40% presence at advanced stage and 10% at metastatic stage. This is in Western data. If you ask me, Indian data is totally different. We see lots and lots of locally advanced cases and metastatic cancer cases. So the whole intention is to increase the number to the early stage where we are able to diagnose these cancers at an earlier stage so that we contribute to the society in a much better way. The whole intention of this topic to educate you guys how to identify this deadly disease at earliest so that we can provide a good scope of life for those breast cancer warriors. So nothing more, nothing less. Not to know about this, not to clear the exams, not to get this kind of MCQs, nothing. Just understand this principle, understand the biology of this breast cancer. So we are able to find this disease at earliest. So we are able to understand and we are able to refer and we are able to monitor the proper treatment what they are getting. And Halster's role, he is the forefather, like the whole surgical oncology and surgical treatment in breast cancer was revolved around this person. He started the surgical procedures for breast cancer, and we will discuss about in upcoming slides. Next slide, please. So I just want to ask all the, hold on. Yeah. So I have made some few very lame animations, Hari. So I'm not very fond of this. So just hold on. So I just want to ask you guys, like, obviously you guys will be on third or second year or fourth year. So you have attended the clinicals, right? So what are the structures which are more important during breast surgery? Can anyone tell me one, two, three, anything, whatever you feel in the breast, whenever we are doing this kind of mastectomies or any kind of a breast surgeries, your colleagues or your seniors must have told you. So these are the important structures which we should know. So can anyone tell me like what are the
Lymph
important
nodes.
structures? Yeah, perfect, perfect. And what I'm asking is like structures to be preserved. So if that is injured, it's a big trouble. Those kind of structures. Lymph
It's
node will
artery,
dissecate.
nerves, veins.
Perfect, 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 perfect. It's Niranjani, right? Great answer,
Yes, sir.
Niranjani. I just want to know what is the artery, Niranjani? It is there everywhere. Wherever we do surgery, we are worried about these three structures only. What is the artery you told? Can you just
Arteries are the structures that supply blood, which gives the oxygenated blood to the organs or the muscles, and veins will collect the deoxygenated from
perfect,
them.
perfect, perfect. Which year, Ranjani, you are? Your first year, right?
Now I'm
First
in
year, second,
fifth year. Fifth year.
fifth year. I just want to name the artery in the breast or axillary region, Anjali, Ranjani. What is the name of the artery which you are worried about? Any idea about that? Because that is the surgical anatomy which I want you guys to learn. Surgical anatomy is not something like there is a breast and we have an so and so artery supplying the breast and we have so and so veins supplying the breast and we have this number of nerves. So that is the level at which we study during MBBS. So I don't want you guys to be in that level. I want you guys to see in a surgeon's perspective. So what are the artery, vein, and nerve? These are the three structures. Any anatomy, any surgery perform, the surgeons are kind of want to preserve it. I will not say surgeons are worried about any structures because once you start worrying about structures, you can't be a surgeon. So to be a surgeon, you know these are structures there. I have to preserve it. So artery is thoracodorsal artery. Yes, you can move, Ari. You can put the slide completely. Nerve. These are the few nerves. Yeah, you can complete the slide. Is it all, Ari? There's one more thing.
Yes, sir.
Complete it. Perfect. Perfect. Yeah, perfect. Perfect. So what I want to know is like artery is thoracodorsal artery, which I will be discussing in the upcoming slides. Nerves, these are the nerves, we'll try to preserve it. And vein, axillary vein. Okay. So these are the structures as a surgeon during the surgery, we want to look so that we can preserve it. Why I want to look, why I want to preserve, what are the functions, we'll see through. So these are the three nerves, intercostobrachial, long thoracic, and pectoral nerves and vein axillary. Next slide, please. So the reason being this is intracostobrachial nerve. It's one of the nerve which provides functionality for the persons. This nerve is identified during the axillary dissection. Obviously, you guys know what is axillary dissection, what are the axillary lymph nodes. I don't want to go into that. Axilla is a space which is present later to the chest wall and medial to the inner arm. So where your axillary lymph nodes will be present. During the dissection, there is a small nerve which transversely passes through that area from the chest wall to the arm. That's why it's called as intercostobrachial. It is from the costal margin to the brachium. So this nerve is a sensory nerve which supplies the medial part of the arm. This is completely encased in the nodal burden. Whenever we are doing the nodal dissection, we try to identify this nerve and preserve it so that the sensation over the medial aspect of the arm is preserved, which is very usual for the any young woman to complain there is a loss of sensation, there's a numbness here, sir. We might say, sir, but what's the big deal when I cut this now? Only the sensation going to be lost. No, the patient will have a complete neuralgia and kind of sensory pain there once this nerve is dissected. So during the dissection, we will, as a surgeon, try to identify this nerve and preserve this nerve. This is one of the important surgical anatomy I just want you guys to know. So the picture says it runs from medial to lateral, sensation to inner arm. It's a lateral cutaneous branch of second intercostal nerve. Next, thoracodorsal pedicle, the important artery which I mentioned previously. You can have number of arteries there in axilla. You can tell axillary artery, whatever way, but this pedicle which contains artery, vein, and nerve, this is what we want to preserve. In the picture, it's very clear that the supplies from the thoracodorsal pedicle also gives branches to the breast. Can anyone tell me what are the main branches of, or what is the main arterial supply of breast? Any ideas? Even random answer I will be happy to have. Main arterial supply of breast.
Internal
Yes.
mammary artery.
Yes, perfect, Santosh. Perfect then. Okay. So it is a
Sir, that was
perforating
not me,
branches
sir.
of.
That was not
Okay.
me, sir.
Okay. So I'm not able to see the person's name. It's okay. You take the compliment, Santosh. It's not a bad thing. Getting compliment from a. You take the compliment, no issues. I can see your face. I'm happy that you have opened your video, but lots of people are like close their videos, right? It's very difficult for me to have an interactive session within a completely shut screen. So the answer is like a perforating branches of intercostal arteries and which are the branches of internal mammary arteries. Along with that, we can see the branches from lateral thoracic as well as thoracodorsal pedicle. So these are the few arteries which gives a major blood supply to the breast. Apart from this, what is the reason we want to preserve this pedicle? The other arteries which I told, it is very rare to get damaged during the surgery. Your intercostal arteries will never get damaged during your mastectomy. Your internal mammary, which is present inside the thoracic cage, will never get damaged during surgery. But this vessel has a risk to get damaged during your axillary dissection or mastectomy. That is the reason I want to tell you this pedicle, which is very essential to preserve during the surgery. It exactly lies in the axilla. From the slide, it is clear that it is a branch of subscapular artery. It runs in the axilla. It is a posterior structure. Can you just put the next slide, Ari? I have the picture there. Yeah, perfect. So you can zoom and see the picture. In the posterior part of axilla, we have this thoracodorsal artery. Yeah.
I tried to zoom, sorry, sir.
No, it's okay, dear, no problem. So that is a very important structure we see during dissection, and it has an implication when you cut it. Next come the questions are why it is so important. If we cut it, will it produce any kind of morbidity for the patient? Yes, because this thoracodorsal artery also supplies your LD muscle. Whenever there's a reconstruction based on LD flap, latissimus dorsi flap, this pedicle has to be preserved. Once you're done with this pedicle, it is very difficult to take that flap. That's one of the very important reasons we always want to preserve this thoracodorsal pedicle so that our reconstruction options for future is always open, right? So this is the second important structure of surgical anatomy I want. See guys, these are not the routine things which you see in routine lectures. That's why I want to take it apart from that. So these are few things which I want to show you guys so that you understand what a surgeon wants clinically. The second important thing is thoracodorsal pedicle. You know where it lies. It is in the axilla. Why it has to be preserved? Because it supplies your LD muscle, which is essential for reconstruction. And this structure is also at risk during axillary dissection. When you do a complete dissection, when you just go posteriorly, this you will see this artery. When you do it very rampantly, there's a chance you might injure this pedicle. That's the reason I just want to show you this. Next slide, please. Third, can anyone tell me what is this long thoracic nerve of Bell? It is already written there. This nerve supplies serratus muscle, and this nerve also identified during your dissection, especially axillary dissection. And where to find this? It is present in the chest wall. From the picture, it is very clear. It's just abutting the chest wall going. Whenever you damage this nerve, it is prone to get damaged whenever you do unsupervised dissection during your initial career of surgery. This cutting of this nerve will produce a winging of scapula, which obviously you guys know during your entrance exams and all. So this nerve, it is found during your dissection and needs to be protected. That's the reason I have mentioned it is another important structure which has to be preserved during axillary dissection. And finally, pectoral nerve has to be preserved, which we don't frequently encounter unless we do a level 3 or level 2 dissections. Just a recap about my MBBS days, like guys, whenever we do this dissection, whenever there's a question and answer from my seniors, what are the structures to be preserved in breast surgeries or axilla? We had this mnemonic called ABC. My seniors used to tell me like A is for axillary vein, B is for brachial plexus, C is for cephalic vein. So if you ask me, you never see these three structures or you never injure these three structures routinely in your dissections. Because axillary vein is a very prominent structure. You see it clearly intraoperatively. You will never injure it unless you go with the intention to injure it. Okay, so it is a kind of huge structure, you can see it. And brachial plexus, you will never see in your dissection. It is behind your brachial artery or behind your axillary artery. And see cephalic vein, it never comes into your view. But somehow we got this mnemonic and we used to say, yes, ABC is a wheel preserve axillary vein, but these things are not routinely followed nowadays. We are least bothered with these three. That's the reason I just want to tell about what are the surgical anatomies, which as a surgical oncologist, we want to preserve. And if you are interested in doing surgery, I want to remember these three structures or four structures, which your surgeon, whom you are observing, will definitely look for it. So this is a basic surgical anatomy. I just want to know you guys. So artery, vein, and nerve, you know what are the names here. So shall we proceed? Is it okay, guys? If it is boring, just do it, man. I'll stop there. Okay? Sure. Yes, please move ahead. Next slide, please. Just one moment. Don't show the answers there.
It's visible, sir.
Santosh is quite happy after seeing the answer. Nah? You tell me, Santosh, what is the answer, Santosh? I just want to know
Page's
about it.
disease.
Yeah, what is it exactly, man?
I don't know what exactly is, but it's somewhat related to without a lump, the cancer may be formed, but I'm not so sure. I didn't study deep into it, sir.
No issues. At least you are able to tell it, right? See, breast cancer, whenever you go to any conference or any structure, any books you read, they always tell that it has few symptoms. There is a lump, there is a nipple discharge, there is an ulceration, there will be some axillary nodes. These are the common symptoms which you guys obviously know about it as an MBBS students or whatever lecture attend, you know about it. I just want to tell you only one thing. Can breast cancer present without any lump? Yes, it can. That's a take home message I just want to know. It is not always present with lump. There are few cancer which you found on screening. So that's the whole intention. I just want to know. If the question says, can breast cancer present without breast lump? Yes. One such example is Paget's disease, where your cancer will just lie on the nipple areolar complex and present as a small eczema or erosion kind of things. When you don't know this, you definitely miss this and you prescribe some kind of antifungal ointment over the breast and you just send the patient for some time, you just go and have something, just come back after some weeks. And you see that patient is telling that no site is not getting cured. I'm not able to, the ulcer, whatever seeing in my nipple area complex is not getting healed. So you should be aware a breast cancer present in the nipple areolar complex with a small eczema kind of things without any lump is called Paget's disease. So just remember this. Just move ahead, man. Ari. Next slide. Next. Yeah, perfect. Perfect. No, just this. Previous one completely. Complete this slide. Yeah, perfect. Perfect. So the same thing. Is it possible for a breast cancer to present only with nipple discharge? Yes. Without lump, only with the nipple discharge, you can have breast cancers. There are multiple cancers like intraductal papillary carcinoma, micropapillary carcinomas, or a screening detected breast cancers, where you will not find any lesions on clinical examination. The whatever signs we read, lump, ulceration, huge nodes, skin tethering, puckering, pudy orange appearance, nothing you will find. So those lesions, you advise a mammogram, you see a nipple discharge, you advise a mammogram, and you see some suspicious features. We'll go for the mammography finding in the findings. I just want to know anyone like Ari or Sridevi or anyone like what kind of nipple discharge we routinely see in breast cancers. Any idea, guys?
Bloody discharge.
Yeah, okay, fine. Bloody discharge points towards malignancy more. There's no doubt about that because patient become more apprehensive. If you ask me, most common type is serosanguinous, kind of serous with an tinge. So it's more of a serous discharge you can take. So whatever words I'm telling, it is not kind of MCQ related, guys. I'm far away from MCQ right now. So don't quote my words for MCQ. I just because Ari is laughing at me that, sir, like we are preparing for my USMLE and FMT and all. So whatever I'm telling is like completely practical oriented, which you see in your daily life. You will get call from your relatives telling that I'm having this kind of discharge there. So what can I do? At that time, I want you guys to be very confident. Yes, this is it. This is not. Okay. So most common breast cancer discharges are very serious only. So if any patient gets a bloody discharge, they will definitely come to you guys. They will definitely go to any doctor. Definitely they're worried about blood discharge. So bloody discharge points towards malignancy. There's no doubt about it. But most commonly breast cancer associated with serious discharges. Okay. So next slide, please. Perfect. Don't move forward, Ari. I just want you guys to tell, lot of findings in breast patient, right? Just can you just tell me what are the, whenever any kind of a patient with a suspected breast cancer, you suspect, yeah, these are the findings I told. So what are the findings you see in the breast which upstages the cancer? I hope you guys understand what is upstaging, right? It increases the stage of the cancer. And you guys are aware about this TNM staging, guys? T stage, N stage, M stage.
Yes, sir. Yes, sir.
Yeah, perfect. T means the size stage, N means nodal stage, M means metastatic stage. So these stages have some clinical findings. So what are those findings? If you see there in a breast patient, which says you, yeah, it is in a higher stage. It is advanced cancer. Can anyone tell me what are those findings which you see in breast patients?
Puckering of nipple.
Puckering of nipple? No. That's the reason I just want to ask you. Why puckering
Enlargement
of
of
nipple?
lymph nodes.
Perfect. Very good answer. Nodes upstages the disease. Yeah, because in malignancy, we are more bothered about nodes. If lymph nodes are there, it directly puts the stage 2, stage 3. Even if the disease is very small, if you got a single node, right, in most of the cancers, not only breast, in most of the cancers, it just upstages to stage 3. We have 4 stages in cancer, right? I hope you guys are aware about it. Any cancer, anywhere in the body you take, we have 4 stages basically: early, and there's a third stage called locally advanced, and fourth is metastatic. Somewhere between these 2 and 3 is stage 2. So we have 4 stages called stage 1, stage 2, stage 3, and stage 4. So if there is a node, it mostly tells the patient is in stage 3. So node is a perfect answer. Any other findings? apart from node? Santu, you
The
told
skin
about the
is
nipple.
Sir,
Yeah, yeah.
like other paraneoplastic syndromes.
No. I just want a clinical finding, Ranjani. I just want a clinical finding. Patient is sitting in front of you.
Sir,
Someone told something else. You are very close, Santosh. You
metastasis.
told something, na? Yeah. Okay, meds. Okay. I just want a finding in breast and axilla. Bas itna.
Puckering of nipple, what
Metastasis.
about that, sir?
Does it mention anywhere in T staging, Santosh?
No, but
You are
it is a
close.
finding, sir.
No, I don't want finding. I want a finding which upstages a disease.
Up stages, okay.
Is
That,
It
there
can be a finding.
metastasis, sir?
Yes, it
Maybe
upstages.
the
You are
limb,
very close.
the lump present over the axillary region.
That is lymph nodes. That is lymph nodes.
Yeah.
Santosh answer was very close to it. What else you see
Sir,
in
maybe
breast patients?
asymmetry.
No,
Sir,
you mean
best
size.
idea.
A very huge size, it upstages, obviously. There's no doubt in that. If you see a small tumor, if you see a larger tumor, it upstages. That is good. And I would love to say, Santosh, if your answer was skin involvement, right? That upstages
POD
definitely.
orange.
Yeah.
POD orange.
Yes. So if you see any patient with breast carcinoma or breast lump, if there's a skin involvement, it upstages disease to T4. We have T1, T2, T3, T4, right? It directly puts a patient to T4 stage. So skin involvement, any kind of skin involvement, it can be ulceration, it can be in pure orange appearance, it can be in a nodules. If you're able to see this now, you say that it is advanced case. There's nothing more. Okay, as Ari said, a larger tumor, obviously it is like advanced. Okay, you can put the slide, Hari. I think Ari is so sincere that he got all the answers within him, but he's not able to tell the answers, right? He got the whole slide. I hope you just revised the slide previously.
It will be not good, sir, if I say
No, that's great. That's so kind of you. Please, yeah, you can go ahead. 1, 2, skin involvement. Yes. Axillary nose. Yes. Next. We are not able to see. Next. Bas. Okay. Investigations. Perfect. So, you with this kind of scenarios, you have a very small assumption that yes, this patient might have breast carcinoma. So obviously, anywhere in the tumor, any cancer in the body, you order some investigations. Always have this in mind, guys. Whenever you order any test for cancer patient, irrespective of the location, order investigation to find T stage, N stage, M stage. That's it. Nothing more, nothing less. If your investigation able to give answer for these stages, now you are okay with that. So we read a list of investigations whenever we read about any cancer, any kind of diagnosis. You just ask your questions whether this investigation is going to help me to find the stage. Yeah, yes or no. If it is yes, that is going to helpful. If you have two investigations, which is going to say same thing about the T stage, why you want to do two investigations for the patient? Two investigation, extra cost for the patient, extra monetary support, extra uh, logistical issues for the patient, right? So you put yourself in a clinician position whenever you order investigation or read investigations. During our MBBS days, we read just everything, right? 1, 2, 3, 1, 2, 3, 1, 2, 3. We'll read everything. Don't do like that. Put yourself in a position. If the patient comes to you, what you will order first. Yes. So that will help you to understand the investigation and tighter your investigation according to your patients. So the first investigation we do is an ultrasound, a simple investigation. If the patient is young, we do an ultrasound. If the patient is old, like more than 45 years, we do a mammogram. Okay. And most probably, I would love to do this sonomammogram, which is mammogram with an ultrasound, where they correlate both these findings so that our sensitivity increases to greater level, right? So obviously, you guys know what is the confirmatory test for breast carcinoma? It is biopsy. Am I right, guys? Yeah, perfect. So it is biopsy. Don't say FNAC. Why? Can anyone tell me why biopsy is important, not FNAC?
False positives, too many false positives in FNACs.
Yeah, Sridevi, you are right. And false positives. No, I'm far away from this PSM, but still I know false positive is not a correct answer, right? False positive means you are telling that it will tell malignant if you are not having malignant, right?
Negative.
Yeah, yeah. False negative is a better answer. It will not able to find the malignancy. Can you able to get it? Because why? Your sample size is very small in FNAC. Your sample is distorted in FNAC, right? So whenever you give some very small sample to your pathologist, right, they're not able to find it very clearly. So that is one of the reason biopsy is needed, and there is another reason which I tell you in the future. That's something called IHC, where we do this ER status, PR status, and HER2 status to titrate treatment. Estrogen receptors, progesterone receptors, and HER2 receptors. This is called IHCs, immunohistochemistry. To find this, we need a biopsy. This immunohistochemistry cannot be done with your FNAC serum. Okay? So next slide, please. Yeah, hold on. So hold. Yes, perfect. So I just want like you guys know these are the basic findings. I just want to do any kind of hide and seek here. These are the findings you see in breast cancer. The first picture shows is a speculated mass where you see the small kind of speculation at the corner, and second picture shows there's an architectural distortion. The whole breast architecture got distorted because of this mass, which you can find mammogram. And the one of the very important thing is microcalcifications. So when you see these findings on mammogram, it says, yes, there is a suspicious for breast cancer. So unless you take radiology, mostly you will not be asked all those things. But for your examination, but for your entrance examination, they will definitely ask you what are the features which you want to see in mammogram. These are the features I want you to remember. These features depicts malignancy. It's architectural distortion, microcalcification, and speculated margins. Yeah, you can move to the next slide, man. Please. Apart from that, only one thing I just want to know you as an undergrad is like, try to read this BIRATS. What is BIRATS? Can anyone explain BIRATS? Okay. There's no need to remove this. It's a kind of a breast imaging and a record system there. That's nothing more than some best breast imaging, reporting, and recording system. So radiologist will see certain criteria in the images, and they give us some numbers to the clinicians. So the number will be BIRATS 0, BIRATS 1, BIRATS 2, BIRATS 3, BIRATS 4, BIRATS 5. These are the reports you guys see in your clinics. So whenever you see these kind of reports, you should know what to be done. So this is a very beautiful slide which shows you if there's a 0, your radiologist says they are not very sure what it is exactly. They want further investigations. So that's what they mean by BIRATS 0, which means you have to repeat the investigation after some time or do another advanced investigations like digital mammogram or do an MRI to further delineate the disease. So 0 means they are not sure. 1 means it is negative or normal. And 2, there's some kind of benign tumors in breast. What are the benign tumors, Sridevi? Do you have any idea what are the benign tumors in breast? Any benign tumors which is most? Yeah, fibroadenoma, one of the commonest benign tumor which you see in young females. A small nodule-like structures which just moves in the breast. So that's probably a benign condition. So that falls under BIRATS 2. And 4 means there's a very high suspicious, and 5 means there's a suspicious, and 6 is a proven condition. For 4 and 5, you have to go for biopsies. Now comes the controversy. What is this 3 BIRATS? So whenever you see the report, they have given probably benign, and they have told you the management as well. You just do a short follow-up that is sufficient for you guys. So what you guys do, you just tell me. You saw a lesion, and it shows BIRAT 3. The patient is your sister or any kind of your mother. So what you guys do for them? We just follow up or take a biopsy for them. Our answer will be, sir, let us take a biopsy. What is going on in biopsy? I can confirm the disease or not, right? Yes or no? Because you just put yourself in the position when you have a lump and if it says BIRAT 3, probably benign. They are also very sure that. So BIRAT 3 says it's a regular follow, but you always correlate clinically. See the patient age group, what kind of clinical picture they have. Is the mass mobile or not? Does he have any kind of signs or symptoms of malignancy? If it is there, just go for biopsy. You are not wrong, right? So it is always a kind of clinical correlation. Apart from other things, you can give an straightforward answers. When there is a BIRAT 3 or in kind of thyroids, you have this kind of Bethesda 3. These are the dicey areas where you have to look into multiple aspects to provide a treatment. So if you want me to ask, sir, what we learned from this session is this BIRAT 0 and BIRAT 3. You remember these two statements. BIRAT 0, we want further investigation. It can be an MRA or digital mammogram. BIRAT 3, we have to correlate the patient clinically. It's not just like sending the patient for follow-up after 3 months. You correlate clinically and guide your treatment accordingly. Just remember these two, you are good enough with BIRATs. Next slide, please. Next slide. So for M, yes. For M stage, obviously it's very clear, guys. So you do test to find metastasis anywhere in the body. You always do this PET CT or CT thorax, abdomen, and bone scan. Nowadays, we are doing PET CT for every patient so that it's a single test which gives a complete results. If anyone asks you what is the test you find to do metastasis in breast carcinoma, the best answer will be PET CT. You will not be wrong, right? Next stage, please. Next slide. So we discussed previously biopsy in IHC. Why you do the IHC? Next slide. Yeah, perfect. So let's stop here. So as an undergraduate, if you are able to come to this position, I'll be more than happy because that's what I just want you guys to know. It doesn't mean that you should not know about surgery or neoadjuvant therapy or adjuvant therapy. So whatever we are going to take from this moment onwards is principal understanding. I don't want you guys to know the surgical steps and how does it going to happen, what kind of complication we are going to develop. Nothing, no need to. You just read bits and pieces here in for your textbooks for examination and all. But one thing I want to know is a breast cancer patient present to you, what she should get. Dot. So this, if you're able to
Yes.
answer this question, right? Yes, Ranjani.
Sir, I thought it was a question and I was about to tell it's neoadjuvant chemotherapy. It
No, I
depends
didn't give
on.
any scenario,
Um,
right, Niranjani?
okay, okay, sir.
So you are right, Niranjani. What I'm trying to tell is like, how do you choose your patients for a neoadjuvant and surgery, Niranjani? Can you just brief for us?
Sir, I think it depends on the size and the mass of the tumor. It's according to the malignancy or not, and according to TM and staging.
Yeah, you are just giving an answer. Just tell me if the patient comes with you
Hmm.
with an 3 centimeter breast lump, it is biopsy proven malignancy. Okay, and there is an single axillary node. Okay,
Okay.
so what do you do for that patient? You start chemotherapy or you give a direct surgery?
I'll start the chemotherapy.
Why?
Because the 3 centimeter, the mass I will break it down. Then maybe if it is not going in that, I will be giving that.
So your answer is like, sir, there's a 3 centimeter tumor. I'll give chemotherapy. If the disease is completely gone, so you don't do any surgeries. You will skip surgery, right?
I may do the exploration surgery.
What is exploration surgery, Ranjani? You mean to say that you explore that area and there's no tumor, you leave it and come out, right?
I'll do the follow up maybe, sir. I'm not so
So
sure.
No issues, Ranjini. I just want these kind of frank answers from you guys because that's what says that what you guys understood, right? So yes, Hari, you want to do something?
Sir, sir, can we proceed with lumpectomy, sir?
Okay, so your
And
answer
followed
is
by
like
radiation.
lumpectomy. So why lumpectomy?
Sir, because of the size margins,
So size is
the
small,
tumor.
so you want to say that you will do lumpectomy. Okay, then why not chemotherapy? See this. Can you able to see? There's a you have a knowledge, but it's not complete, right? So this session is to fill the gaps here. That's the reason I just want you to reciprocate. See, in a way, both of you are right and wrong. Okay. So only thing is like Ranjini or any Andari. So there's nothing called as you give chemotherapy. If the disease is completely vanished, you don't do surgery. It is not. There's no studies or nothing. Something like we have given chemotherapy. If disease is completely resolved, we don't do surgery. No, there's nothing like that. Even if the disease is completely resolved in neoadjuvant chemotherapy, still we do surgery. Still we do surgery. I will tell you why. Okay. Still we do surgeries. The, the principle which I want you guys to learn is why surgery first, why neoadjuvant first, in which case we give this first. Okay. So slide, please move on the slide, man. I'll tell you. No. Just come to the previous one. Come to the previous one. Yeah. Do you have anything written below that? Exactly. So in cancer treatment, we do something called as removal of the cancer along with removal of the lymph nodes. This completes the treatment. If anyone asks you what is the treatment of choice for breast cancer, it is surgery. Nothing more, nothing less. Okay. Along with the surgery, we give chemotherapy as an adjuvant. Adjuvant means along with that. And we give radiotherapy along with that. So these two modalities supports your surgical treatment. It is not replacing your surgical treatment. So this you should be very clear. And if it is not replacing, your answer cannot be something like chemotherapy we will give, and if it is completely managed, we will just wait and watch. No. Can you able to got my point? Chemotherapy and radiotherapy are adjuvant. They are going to help your surgery. Help, helping hand cannot be a main treatment. So that if you know this concept, now you will be able to tell the answer properly. So we know what is the role of surgery, what is the role of chemotherapy, what is the role of radiotherapy right now. Radio and chemo are helping hands. The main hand is going to be a surgery, surgical removal. Now comes the question, sir, which patient will go for surgery first? Which patient will go for neoadjuvant first? In a broader term, just remember this alone. Early breast cancer, go for upfront surgery. Locally advanced breast cancer, go for neoadjuvant chemotherapy. Just a simple answer. There are multiple branches within this section. I don't want you guys to confuse with all these things. If someone asks you, sir, it is an early breast cancer, you should know what is early breast cancer. That you guys know. Can you tell me what is early breast cancer? Just a
Stage
lame
1 and
statement, man.
stage 2, sir.
Yeah, okay, perfect, beautiful. So early stages, small size tumors, less than 2 centimeter, 3 centimeter. There is no axillary nodes. There is no skin involvement. So those are the very early stages. Early stage, I'll go for upfront surgery, sir. If it is a locally advanced, like stage 3, I'll give chemotherapy. Why chemotherapy in locally advanced? Any just whatever coming to your mind, you're still. I don't want a I don't
Because
want a
the
proper
lymph
answer.
node involvement.
Yeah, good. Why you want to give lymph node involvement? You can do lymph node dissection as well, right? Yeah, I'm told right. You are doing a surgery, you're going to address the lymph nodes. Why you want to give a chemotherapy first? Any random answer. I'm happy to have a random answer, no issues. No need for educated answers. So the reason being, guys, breast cancer, even though it's a surgical disease, it is a systemic disease. You know what is systemic, right? It is already in the blood. It is already in the blood. Even if it is small, it is already in the blood. So whenever you are addressing a systemic disease, your local surgery alone will not provide a complete cure for it, because there are few microscopic cells which would have invaded the bloodstream as circulating around the body. So that is the reason for your distant meds or your failure or your recurrence. So whenever a disease is systemic disease, you need some kind of systemic treatment. Chemotherapy is one such systemic treatment where you give chemotherapy. The chemotherapy agent will go through your blood and goes to the complete body and destroy any kind of cells anywhere in the body. Are you guys with me? Yeah.
Yes,
Yes,
sir.
sir.
Perfect. So that is the reason in locally advanced cancers or LABCs, there's a high propensity that the disease would have metastasized to some other areas. Even if it is not visible in the scan, we want to control that as well, and we want to reduce the tumor burden as well. That is the reason you give neoadjuvant chemotherapy in locally advanced breast cancers, because you don't want the patient to fail somewhere else. You remove the disease in the breast and axilla, but you see after 3 months patient have an bony metastasis, patient have a liver metastasis. So that should not happen. That is the reason, to see the biology of the tumor, biology of the response, we give chemotherapy first in locally advanced breast cancers. But in early breast cancers, it is mostly localized. We just remove it and we follow with an adjuvant chemotherapy. Okay. So let us not confuse you guys with more these details. Just remember, early breast cancer, I'll go for surgery first. Locally advanced, I go for neoadjuvant chemotherapy followed by surgery. That should be a complete answer. It's not only neoadjuvant chemotherapy. Neoadjuvant chemotherapy and followed by surgery. Right? Move ahead, man. Hari. Yeah, perfect. Just complete the slide. Complete the slide. Halstead. Then, yeah, then next. Perfect. Hold on. So surgery, I want you to see this is the surgical advancement we have reached till now. The surgery which was done by Halstead 19 surgeries are very, very radical, which means what is mastectomy? Removal of breast. Apart from removing breast, in 18th century and 19th century, they assumed that removing everything from the chest wall is essential to give a cure. Because those are the times we don't have chemotherapy and other helping hands. So the surgeons used to remove everything: breast, skin over the breast, pick major muscle, chest wall, axilla, everything. That's called as radical mastectomy. You remove every structure in the chest, that's called radical. After that, we came to a treatment called modified radical mastectomy, where you remove only the breast tissue with skin preservation, and you remove the axillary nodes from level 1 to 3. This is called modified radical mastectomy, which we are doing currently. After this, in the current era, we are doing something called as breast conservation surgery, as Hariharan told us, lumpectomy, sir. Just remove the cancer with a good margins of normal tissue. That's called lumpectomy, by which you can preserve breast for the females. So this is the current era. We do more of an breast conservation surgeries like lumpectomies. Our intention is to remove the tumor along with preservation of breast, because breast is such an important organ for the females to give a social and dignified life. It's not something like an extra organ or organ for lactation. It's a social image organ. The females have a huge social trauma after mastectomy. That's the reason we always have this mastectomy followed by some kind of reconstruction for them to give this good social life, or we give them this option called breast conservation surgery so that the breast appearance is preserved. So they are getting cured from cancer as well as having good quality of life. If you see, the whole treatment goes from radical to minimally invasive. Next slide, please. Next slide. Yeah, next slide. It's done there. Next slide. No need. Next slide. Yeah, perfect. So as I told you guys previously, breast cancer is a systemic disease. Even though surgery is the main treatment modality, surgery alone will not provide cure for the patient. Just remember this statement. I'm so happy for this whole session. If you're able to remember, in breast cancer surgeries, we need surgery, which is more important. Along with that, we need chemotherapy as well. If you know this sentence, you will not fumble by giving answer that I'll just give chemotherapy, I'll just do nothing, because there's no answer something like that. I'll give chemotherapy, then surgery, or I do surgery followed by chemotherapy. These two treatments are very essential for breast cancer patients, right? Next slide, please. Next slide. No, just one slide. Previous slide, man. Yeah. Yes. So this we discussed when to give neoadjuvant chemotherapy. When there's a locally advanced cancer, we give chemotherapy, or as Ari told, there's a small lump, sir. We can go with lumpectomy, no issues. If there's a larger disease, but patient wants lumpectomy, then what to do? Then give this neoadjuvant, as Niranjana told. So we try to reduce the tumor size. So in those circumstances, we give chemotherapy to reduce the tumor size, and then we perform a surgery. So that's what, when patient wants BCS, but the current situation is not eligible for that. Then you give chemotherapy, convert it to a smaller size, then do BCS for them. Are you able to get it? Perfect. So the third point is quite confusing for you guys. You just leave that alone. Currently, even for early cancers, there are very few histologies like triple negative breast cancers and HER2 new positive cancers where we give neoadjuvant chemotherapy because the response rate are very higher. We have a very good PCR, that is pathological complete response. So we just want to give neoadjuvant for those patients to see the biology of the disease. But that will be quite confusing for you guys. At the end of the day, if you tell them even for every early breast cancer, I'll give chemotherapy, that will not be a very good answer. So it's just a step by step. You remember early breast cancers, surgery, advanced breast cancers, chemotherapy. That's more than sufficient. And if the patient is not eligible for BCS, I give chemotherapy and convert it to BCS. That if you're able to remember these basic steps, I'm happy. Next slide, please. Okay. So now comes the question. Yeah, perfect. Once the surgery is done, as we told, we need chemotherapy, right? And we also give radiotherapy for selected patients. I want you guys to remember only one indication each, so which you can continue for a whole life. When you give chemotherapy, any tumor which is more than 1 centimeter, the patient needs an adjuvant chemotherapy. Simple as that. No more complex statements. If the breast tumor size is more than 1, the patient needs a chemotherapy after surgery. There is no doubt in that. At the same time, in axilla, if a single node is positive, the patient needs an adjuvant radiotherapy. So whenever anyone asks you, what is the indication for adjuvant chemotherapy? What is the indication for adjuvant radiotherapy in breast cancer? Just remember this one indication that is more than sufficient. You will be happy in 90% of cases. More than 1 centimeter, you need an adjuvant chemotherapy. If the single node is positive, you need an adjuvant radiotherapy. Perfect. I just want you guys, are you guys aware about this kind of receptors, estrogen receptors, progesterone receptors, HER2 receptors? Can anyone
Yes.
tell me what are those receptors? How it is useful? Why we are doing this receptors?
Sir,
Yes, Niranjana.
in breast tumors, like in malignancy, there will be change in the hormonal levels. So to control that and to change, to modify those receptors, we give the hormonal therapy and the trastuzumab, which used to like monoclonal antibodies, which is again used in like IL-2 receptor inhibitors of those interleukins.
Okay, Niranjana. So to be put in a very local language, I'll tell, basically, we want to find whether this breast cancer is a good cancer or not. Simple as that. The cancer is a bad thing, but there are certain good cancers, there are certain bad cancers in the breast cancer itself. So how to find those? Because good breast cancer have a good prognosis, good overall survival, good response to chemotherapy, right? So bad breast cancer have a very poor survival, very high recurrence rate. So to delineate these two, we do something called as receptor studies, right? So what are those receptors? estrogen receptors, progesterone receptors, HER2 receptors, and Ki67 proliferation index. These are the 4 things we routinely do for all our breast patients by using IHC technique, that is immunohistochemistry. All these tests are done on the breast biopsies. So you guys are with me? Yes. So these tests are done in a breast
Yes.
biopsy tissue to find which receptor is positive, which receptor is negative. So we have this background. According to this test, which is a good breast cancer, any hormonal positive. What is hormonal positive? ER, estrogen receptor positive, or progesterone receptor positive, or good cancers. If these receptors are negative or HER2 new positive receptors, they are bad cancers. Why? Because we haven't target to act on this. So that just the take-home message will be hormonal positive tumors are good tumors, hormonal negative tumors are bad tumors. Just remember this thing alone. I'll be more than happier. So if the report says ER/PR positive, you can reassure the patient, yeah, that's a good thing for you because you have some hormonal status. We can give anti-hormonal therapy for you, so which has a very good response rate. If these 2 receptors are negative, you cannot give hormonal therapy for them because it is not going to act on the receptors because the receptors are already negative there. There's no receptor there. So is it okay or am I confusing you guys? Sridevi, is it okay, Sridevi? No,
Yes, sir.
you don't seem to be okay. So basically, guys, we just do this test to say, is it a good or bad cancer? Hormonal positives are good cancers, hormonal negatives are bad cancers. Just keep that way. That's more than sufficient. Okay? Yes, we'll move ahead. Next. Next. Yeah, perfect. So far we understood any breast cancer patient, what I'll give for the patients, what kind of a principal treatment I provide for them, and what kind of adjuvant treatment. Adjuvant means after surgery, right? Adjuvant treatment, what I give for patients. You know, when there's more than 1 centimeter, I give adjuvant chemotherapy. When there's a more than a single node positive, I give adjuvant radiotherapy. I don't want to dive into like how many cycles of chemotherapy you do, how many cycles of radiotherapy you do. That you can see empty number of lectures out there. You can read and you can learn. So only principle I want to know. These are the principles you know, you remember. Because once you know very few things, right, you remember. You don't confuse yourself, right? So once you got the complete treatment and you have your relatives asking like, what's next? Am I completely cured or I should go follow up? All breast cancer patients need a follow up. Why follow up? To find the recurrence and to see the complaints to the treatment. Are they finding any recurrence or are they complain to the treatment? So to find this, we need a follow up. How frequently we follow these patients? The chart is there. In the first 2 years after the treatment, call those patients every 3 months to your clinic to see and to examine, right? So see what is any problem with them, and in the local examination, any notes are there, you find that. And after 2 years, call them every 6 months to your OPD to see any problem there. If they are having no problem in the first 5 years, call them annually, once in a year to visit your OPD. So this is the complete follow-up. During this every follow-up, what you will do is examine the breast or chest wall, examine the axilla, and do an mammogram annually. One single mammogram annually is sufficient to find any recurrences. Next. Yeah, perfect. Perfect. So this is a very, very, very brief talk